part of our virtual Blood Cancer Patient Forum for 2021. My name is Natasha and I'm one of the Support Services Coordinators for Leukaemia and Blood Cancer New Zealand. I'd like to extend a very warm welcome and a big thank you to Professor Peter Browett, who is here with us today and who I'll introduce shortly. Firstly, I'd just like to give everyone tuned in a bit of information about how today's session will run. So shortly, Peter will share with us his presentation and you're all welcome to submit questions as we go in the Q&A section at the bottom of your screen. These will be answered at the end of our talk. So we'll have a range of talks happening today and we'll be aiming to wrap up at around 11:20, just to allow time for those of you who might want to tune into the next session to be able to move over. And this will mean that we may not be able to get through all of the questions that we hope to, but if we do miss some, we'll see if we can answer them at a later date. And it's also worth noting that the session will be recorded and it will be posted on our YouTube page at a later date. So I'd like to introduce Peter, who is the Professor of Pathology and Head of Department at the Molecular Medicine and Pathology at University of Auckland School of Medicine. He is a Consultant Haematologist at Auckland City Hospital. And Peter has had a long association with LBC, acting as the Medical Director and Trustee for many years, and has more recently joined LBC's Independent Medical Scientific Committee, overseeing research grants. So on that note, it is my pleasure to hand over the time to Peter for his presentation. Thank you, Peter.
Thank you, Natasha. So let me just open up my slides. Thank you. So you can confirm that everyone's seeing my slides?
Yeah, looks great.
Great, thank you. So look, thank you so much, and thank you everyone for dialing in. I'm sorry we're not in person. This is such a great forum for patients and their families, and we as the clinicians and those involved with LBC always enjoy sort of attending it and having a chance to sort of talk to you. So my task today, what I want to do is talk around chronic leukemias, sort of advances or what is new. And I appreciate that there's going to be two groups of people here because there's really two main chronic leukemias. So this, when I'm talking to students, I always say this is the picture of life. So this is the normal blood cells. So here's the stem cell. When we do a transplant, this is what we transplant. Here's all the mature blood cells that circulate in our peripheral blood. So the two chronic leukemias, there's a number of chronic leukemias, but the two main ones are the one that affects the myeloid lineage, and particularly the neutrophils or granulocytes. That's this cell here, and that's CML or chronic myeloid leukemia. And the one that affects our lymphocytes, the immune system cells. So that's the lymphocytes and the B lymphocytes, and that's CLL and chronic lymphocytic leukemia. And they're both chronic leukemias that there's been huge advances in understanding the biology of the disease and the treatment in the last decade, and in CLL over the last 4 to 5 years. Natasha and I are just talking, and I really don't know, whether our mix is going to be more CML or CLL patients. I suspect the more in the CLL. So I'm going to talk CML initially, and I've got some new advances and things to raise, and then move to CLL. And there's some things that have happened in CML that are now starting to happen in CLL. So I think there's some relevance, even if your interest is in CLL, I think you'll see some common themes emerging. So it's relevant to be talking about chronic myeloid leukemia because this is Blood Cancer Awareness Month. And on the 22nd of September is World CML Day. And you say, well, why the 22nd of September? And that's because the key feature of CML is the Philadelphia chromosome, and that's a chromosome change between chromosomes 9 and 22, as shown here, and that's the driver. That's what causes the leukemia, and it's the protein that's made from this chromosome change that we target with our treatment, and that's allowed the evolution of treatment and the significant improvement in outcomes in chronic myeloid leukemia because of the discoveries. And of course, in America, for some reason, they flip around the day and the month. So they call the 22/9/2021. So 22nd of the 9th is in the US, they call that 9/22. So that's World CML Day. So if we look at chronic myeloid leukemia, and we're starting to look at CLL in a similar way, is that with the development of drugs that target the protein made by the Philadelphia chromosome, it's improved outcomes dramatically, such that for a patient diagnosed with a CML in 2020 or 2021, we expect them to have a near normal life expectancy. And the evidence for that comes from a number of sources, but this is from the German Leukemia Study Group. And you'll see a lot in the talks that over today, these curves that we call them Kaplan-Meier curves. So what we do is we put all the data from clinical trials, and it gives us the probability of a patient either staying in remission or even their overall sort of survival. And so this is the probability of survival. So this is back 2 decades ago with the chemotherapy that we used to use, when the median survival for this condition was 4.5 to 5 years. And now with the targeted treatment, imatinib and those drugs, the survival is very close to someone of the same age who doesn't have chronic myeloid leukemia. So then you might quite correctly sort of say, well, if that's the case, why don't we just go straight on to CLL? What's new in CML? And there are new things always happening, and there's just new guidelines come out that help us as clinicians manage our patients. But I think there's 3 key things that I wanted to discuss with you. One is, how do we choose which treatment to give a patient with CML? Because we've now got a number of targeted drugs. And the move is towards choosing treatments that are the best for an individual patient based on their other medical illnesses. So trying to minimize side effects or risks of side effects. The second key point is around molecular monitoring and achieving what we call deep molecular remissions. And that's a theme that's going to come up in CLL as well. And then the third new theme that's coming through and is in the new guidelines as a goal of treatment is that, do patients need to stay on their tablets forever? Is there an option for coming off the tyrosine kinase inhibitors? So if we look at the first question, what's the optimal frontline treatment? So in New Zealand, we have 3 tyrosine kinase inhibitors that are funded in CML. We've got imatinib, which is the first drug. We call that a first generation drug. This is the abnormal protein. This is the driver for the leukemia. And this is where the targeted drugs, so these are smart drugs, and this is where it's binding. These are second generation drugs, nilotinib and dasatinib, and they're all funded in New Zealand by Pharmac for treatment of chronic myeloid leukemia. And again, you hear me when I talk about CLL, as we've moved into an era now of targeted drugs as well. So not broad spectrum chemotherapy or cytotoxic drugs, but drugs that actually target the leukemia cells. So when we're choosing the treatment, we've got a number of the goals that we're looking for. So we want patient to have a normal life expectancy, and to do that, we need to get the patient into a good remission and what we call a deep molecular remission. The second is for any treatment, but we want patients to have a good quality of life, to minimize the side effects. So we're going to look at the age of the patient, what other medical illnesses they've got, and that's going to help us choose treatment. And as I mentioned in my what's new is that, do you have to have your treatment forever? Is there an option for coming off therapy? There's still debate worldwide about what the best frontline treatment. Should it be the original drug, which we've got lots of experience with, has some very mild initial side effects, but there is no, with over 20 years of experience, there's no unexpected long-term side effects? Or do we use a second generation drug that are more potent, but as I'll show you, carry the potential for more long-term side effects? And that's important because a 40 or 50-year-old diagnosed with chronic myeloid leukemia could potentially be on these tablets for another 30 or 40 or 50 years. This is just to show you the debate. This is from some headlines of articles that are published in prominent hematology journals, and these are from leaders in the leukemia field. So this one, imatinib is still recommended for frontline therapy, and this from Jorge Cortez at the MD Anderson Cancer Hospital in Houston, saying, no, a second generation drug should always be used. So what's the difference? So the second generation drugs are more powerful. So patients go into remission faster and they get into a deeper remission. This is from one of the studies comparing a second generation drug. This was called the Decision trial, and patients either got dasatinib, the second generation drug, or imatinib at the time of diagnosis. This is the percentage of patients that get into what we call a major molecular remission. So for those with CML who are used to monitoring and looking at their PCR results, this is a level less than 0.1%. And so the blue line is dasatinib, and you can see patients get into that molecular remission faster and deeper. This is months from starting treatment. This is the imatinib arm here. So there's both nilotinib and dasatinib. You get into a deeper remission, you get there faster. Does that mean that in 5 and 10 years' time you're doing better? No, the survival for patients is very similar, but then the studies weren't designed to answer that question. So then you say, well, why don't we just give everybody a second generation drug? And the problem with that approach is that there are more side effects and long-term side effects with the second generation drugs. And I don't want to go through all of them, but this is just showing this is the risk of vascular side effects and heart side effects. So this is heart attacks and poor peripheral circulation for nilotinib versus imatinib. So the red curve is nilotinib at a high dose, the blue curve is nilotinib at a low dose, and the green curve is imatinib. And so you can see this is what we would expect in the population. So there's a higher risk of vascular toxicity or vascular side effects with nilotinib compared to imatinib. And that's why when we have a patient on nilotinib, we try and use the lowest dose we can, and we're very careful around monitoring other vascular risk factors like smoking, cholesterol levels, glucose levels, lifestyle, and so forth. So those are the balancing things that we choose. We've got a better molecular response, but potential for more side effects. This is guidelines that have come out from the British hematology group. And I don't want you to look at it in detail, but what this table, it helps us as clinicians. Down here, a number of illnesses that a patient in their 50s or 60s might have. So high blood pressure or diabetes or heart failure. And here's the different tyrosine kinase inhibitors. And green is one we can use safely. Red is one that we shouldn't use. And orange and yellow are sort of, it's a low or intermediate risk. So what I'm showing this slide for is that when a new patient comes to us and they're diagnosed with chronic myeloid leukemia, I'm going to look at what other illnesses they have and their risk factors for their CML, and that's going to guide me as to what recommendations we might make around which drug to start first. In New Zealand, and some of you might be on this is a trial that's funded by Leukemia and Blood Cancer called the KISS study, and it's trying to help us ask this question. And all the main leukemia centres in New Zealand are enrolling patients on this trial. So patients get initially a second generation drug, dasatinib, with the aim of getting quickly into the molecular remission, so into what we call a safe haven. But then after 12 months, if they've had that very good response, will transition back to the first generation drug, imatinib, which we know has got a very good long-term safety sort of profile. So we're trying to get the best of both our drugs, and that trial has now got 83 patients on it, and we're aiming to recruit 100 patients. So that's going to contribute to knowledge around what the best first drug is. Outside of the trial, so the situation in New Zealand for a new patient, imatinib is funded for first-line therapy. Dasatinib is funded for first-line therapy as part of the KISH trial, or patients that have got very high risk CML at diagnosis. Dasatinib and nilotinib are both funded for second-line therapy. The other drugs, bosutinib, is not funded in New Zealand, and ponatinib, a third-generation drug, is also not funded in New Zealand. So the second area it's not so much new, but it's incredibly important. And as you'll see in my CLL part of the talk, it's also becoming important in CLL as well. And that's the concept of molecular monitoring and achieving milestones at particular time points. So when I started training in haematology, when I was a haematology house surgeon and registrar, patients with chronic myeloid leukemia received chemotherapy drugs, and the main milestones that patients were interested in was how big their spleens were and how high their white count was. We tried to get the white count down to between 10 and 20 and the spleen down as small as we could. Now, most of you are familiar with not worrying about your blood count or the spleen side, but you want to know what the PCR is. So this is molecular monitoring. And what this diagram shows is the black dots are the leukemia and the amount of leukemia. So here's a patient at diagnosis where all through the bone marrow is leukemia. Here's after 3 months treatment and the level's down to 10%. And here's after 6 months, 12 months, and I think this is 18 months. And our goal is to get the level by 3 months down to 10%, and by 12 to 18 months less than 0.1%. And it's using this molecular sort of monitoring. We call it PCR. PCR is like a molecular photocopier. It makes lots of copies of the leukemia gene in your blood cells, and this is the leukemia gene made by the Philadelphia chromosome, the BCR-ABL, and that's what we're sort of monitoring. And that's revolutionized the way we treat CML. And it's really important that we have these regular monitoring initially at 3 months, and then perhaps 3 to 6 monthly if everything's very stable. I tend to continue everything at doing 3 monthly sort of testing. And again, it's starting to, what we've learned from this in CML, we're using in CLL now as well. And the final topic that I wanted to talk to you about in CML is this goal of, do you need to stay on your tablets for sort of ever? And this has it's moved from being in the research arena as part of clinical trials now into could be or should be a goal for treatment. And really is, essentially what we're saying is, can a patient with CML, can they stop their tyrosine kinase inhibitor therapy? So their imatinib or their dasatinib. And it's become a goal of treatment. So you may say, well, I'm doing really well on my imatinib. Why would I want to stop it? And not everybody wants to stop their drug, and not everybody needs to stop their drug. But there's a number of factors that do drive patients to wanting to ask about, can you stop the TKI? And if you're always taking a tablet, that's like someone with high blood pressure or diabetes, you stay on your treatment. So that concept of could you be cured if you're able to come off the treatment? As I mentioned earlier, there is side effects. These treatments, even though they're smart drugs, they're not totally without risk. I've used this term, financial toxicity. It's not a term. In New Zealand, we've got a publicly funded health system, but in some countries, for example, the United States, is the insurance companies are paying for these drugs. Some patients may not have medical insurance, or they may lose their medical insurance. So there's real issues for these drugs. And of course, for a young woman with chronic myeloid leukemia, these drugs can cause harm to the developing embryo and fetus. And so if a patient wishes to become pregnant, they need to come off the drug to become pregnant. There are now over 20 studies published in the literature with over 2,000 patients from all the continents, including Australia, including Europe, including the UK, including US and Canada. And they all show similar findings in the stopping studies. So this is the biggest study. This is the Euro stopping kinase inhibitor, or the EuroSki study. And what it's doing is looking at this slide here shows what are the probabilities of staying in a molecular remission if I come off, if I stop my imatinib. So this is the percentage of patients who are able to stay in remission. So off there, so there's initially 100% of patients come off their tablets, and then where the curve flattens out, it's somewhere between 50 to 60% of patients at 2 years have remained in remission, still off their imatinib tablets. So that means about 40 to 50% of patients do have a molecular relapse. It's not a clinical relapse, it's just they become PCR positive again. They go from being negative or very low levels to having levels over 0.1%. And you can see almost all of those occur in the first 6 to 12 months of starting treatment. So if we ask the question in New Zealand as of September 2021, is this part of our sort of treatment? And the answer is yes. As clinicians, there is enough good data in the literature. It's now being incorporated into all the international guidelines. And we would estimate that about 50 to 60% of patients can successfully come off their treatment and remain in a remission. For those patients who don't stay in remission, who become positive again, all of them go back into remission when they restart their drug. So that's the other thing we have to ask: is this safe, or is there any risk of losing control? And the answer is no, it's very safe to do this. So we, and sure other centres around the country have done the same. These are our guidelines for stopping treatment. So we only stop it in patients that are in the chronic phase of their condition. We only consider it as if they're on their first line of first TKI, or have changed because of side effects, not because of resistance. The best results are for patients who have been on their TKIs for some time. So over 5 years is our recommendation. And patients need to be not just in a less than 0.1%, but a nice deep remission, so less than 0.01 sort of percent. Unfortunately, you still need to see me or your haematologist, and we still need to do molecular monitoring, and quite intense, more intense early on after stopping. So monthly for the first 6 months, and then for the second 6 months, every 2 months, and then 3 monthly after that. And the reason that we still need to continue with the monitoring is that there's some late molecular relapses. So I've had a patient who was successfully off for 2 to 3 years and has just become positive again and has needed to go back onto treatment. So those are the main comments that I wanted to make around sort of CML. And so just reiterating that the new advances are around, one is choice of treatment is based on trying to minimize side effects of therapy, but maximizing the benefit of the treatment. Second is that molecular monitoring is key and is really, really important. And the third, treatment-free remissions, coming off treatment, is becoming a new objective, a new guideline for our treatment. I just see a couple of questions. So I was going to do all the questions at the end, but I might just deal with these while we're thinking CML before I move into, okay. So there's one CLL question and one CML. So the CML, read the qPCR test of an unusual mutation, which has meant the BCR has not been able to be done. Unique test will need to be set up. Has not been able to be done by the lab. Should I be concerned about this? So no, I don't think so. We have, and I'm not sure if you're an Auckland patient or a Christchurch sort of patient, because I think Christchurch have had a patient or 1 or 2 patients with. So there's some variant sort of transcripts, and the standard assays for monitoring for the qPCR don't work in that setting. What we can do with we still are able to do the molecular monitoring, and what we do is we nest it, so we can see what's happening for transcript levels. So we can't put an exact number beside it, like 1% or 0.01%, but we can sort of estimate where we're going. Actually, it's going to be quite difficult for the lab to set up for that assay, and even internationally, most labs don't have a molecular monitoring for it. But I think we can still see the level. You can see the level, although we can't put an exact number to it. We've got an estimate, and we can see that. And Joanne, I'll come back to your question and answer that. Okay, so I want to move on to CLL, or chronic lymphocytic sort of leukemia. So this is again a bone marrow neoplasm or cancer. It arises in these B lymphocytes, and this is what it looks like in the peripheral blood. And it's the most common sort of leukemia that we see in our country. So 4 to 5 patients per 100,000 population per year. And as one of the questions raised is that, you know, the median age is around sort of 70, and that has relevance when we're thinking about sort of treatment and also long-term sort of prognosis. So what are the advances in CLL? And there's a whole lot, and I guess most of them are around the advances in therapy, and it just we as the clinicians, just the clinical trials and the data is just, you know, it's moving very quickly. But I wanted to raise 3 areas with you. One is around better prediction. So what, you know, prognosis when a patient's, and the question that came up was of someone who's diagnosed in early stage as asymptomatic. You know, well, you know, it's still there. How can you get as much information as you can? And then if you're needing to start treatment, you know, what things might guide treatment, you know, what things can help guide the clinician and their recommendations. The second is around the move from chemotherapy to chemoimmunotherapy, which is the era we're in New Zealand at the moment into the targeted therapy, which is where increasingly where the world is moving to. And then thirdly, similar to what I was discussing in CML, and is the cornerstone of CML treatment is around, you know, that molecular monitoring. Is we're now moving away from just clinical endpoints, but you know, the depth of remission and monitoring, and this concept of minimal residual disease. So that's the concept, that's the monitoring we do in CML, looking at those very low levels, is that's moving into the CLL field as well. So the first thing is that if we look at when a patient's diagnosed with CLL, is that your clinician will talk about the clinical staging. So look at your blood counts, the hemoglobin, the neutrophil count, and the platelet count, and put that alongside, are there any enlarged lymph nodes, and how large are they? Is the spleen enlarged, and how are you feeling in terms of systemic or constitutional sort of symptoms? And they go into these conventional clinical staging systems named after famous clinicians. So Binet is from the Europeans, French, and Canty Rye, who's aged about 90 and still comes to CLL meetings from the US. And they give us quite good prognostic information, and they guide when to start treatment. So patients with early stage CLL, so RISE stage A, you might have heard that term, or Binet stage 0, often don't need treatment. They'll do observation only. But like all areas of hematology, we're moving into looking deeper into the cells and looking at the gene changes that occur in the leukemia cells. And this has also happened in CLL and is really important. And we do chromosome or FISH studies, and my next slide will explain that, and immunoglobulin studies, or the immunoglobulin gene mutation status, and not yet ready to roll out, but I think in the next few years is going to become important, and we've got a research project starting to look at this. And so these two are becoming an important part of the initial workup and guiding us in treatment. So when you hear us talk about FISH studies, so this isn't going under level 3 down with your fishing rod and sticking it into the Avon and looking for fish. This is an abbreviation for fluorescence in situ hybridization. So this is a way of looking at chromosomes, or looking at genes or bits of the chromosome or gene. So we have some gene probes that bind onto, for example, chromosome 17 or chromosome 21, and we put green or yellow or red fluorescent dyes. We attach that onto our probes, and then we stick it onto the cells, and it binds on to the chromosomes or the genes, and it'll fluoresce. So if you look into this bottom left-hand panel, you can just see here's the shadow of a cell here, and these red dots, this is a probe that's got a red fluorescent marker on it. Most cells, if you look at a chromosome or a gene, you have 2 chromosomes in each of each type in a cell, and or 2 genes of each type. So you'd get 2 red dots or 2 green dots. This is a gene where there's heaps of red dots, so there's lots more copies of a gene. This is actually from a breast cancer sample looking at amplifications and more copies of the HER2 gene. So when we're looking to start treatment in a patient with CLL, we'll analyze their CLL cells. And if you look, first off, if we look at the left-hand panel, so this is looking at the 4 genes that we commonly look at. We call this a CLL panel. Some hospitals and some labs and some clinicians just look at this one, chromosome 17, because that's the most important one. And at the moment, it's the only one that alters a treatment decision. We look at them all because it just provides greater information for us. Where it says del, that means deletion. That means that bit of the chromosome is gone completely and all the genes that are on it have gone. Trisomy means that you've got, rather than 2 copies of chromosome 12, there's 3 copies. So we look with these with our fluorescent probes. And on the right-hand panel, this took a series of patients who had CLL. They were treated with older start type of treatment, so mainly chemotherapy. And this looks at survival for patients. And so you can see these are all fairly similar. That's the chromosome 13, 11, and 12 changes. And this is chromosome 17, where there's deletion of chromosome 17. And you can see these patients don't do as well with conventional treatment. And that's because on chromosome 17 is this gene called TP53. And TP53 is like a molecular policeman. So what its role is if you have cells that have got something wrong with them, if they're sick, then it sets up pathways that make that cell divide. Not divide, cell die. So if you had a cell that perhaps had a cancer-causing change in it, that TP53 turns on the cell death pathway and the cell dies off. So if that gene's not working, then it allows those other abnormal pathways to be more sort of active. So this is important in CLL, and we look for it. We look for loss of chromosome 17, and also we sequence the TP53 gene looking for sort of mutations. And so here on this panel, here's TP53. Wild type means it's normal, and this means it's abnormal, either loss of chromosome 17 or a mutation. And what this slide's tried to show, and I'm pretty sorry, it's got whole lots of graphs on it. It's got, if both your 17 TP53s are normal, this is where if you've got both a deletion and a mutation, and then if you've got one or the other. So this is important information because we need to use different treatments in these patients, because patients that have got a deletion of chromosome 17 or a TP53 mutation, they don't respond well to conventional therapy, but they do respond well to the new drugs, to ibrutinib and Venetoclax. And Venetoclax is funded by Pharmac to treat patients that have got this change. The other thing we look at is the immunoglobulin gene status, whether it's mutated or non-mutated. So CLL is it's a cancer of B lymphocytes that make immunoglobulin. So when you get vaccinated, for example, against COVID, you're making an antibody, and this is the heavy chain part of it. And within CLL cells, they can either be mutated or not mutated. And this is a slide for me to talk to, not for you to look at. And but this is showing it where it's mutated, and it depends where the CLL forms. This is the non-mutated. And we've known for many years that patients that have got an unmutated gene don't respond as well to treatment. So we've got 2 important bits of information: the FISH status, and particularly TP53, chromosome 17, and the immunoglobulin gene status. And this is guidelines from the Europeans. They should be looked at in patients that are needing treatment because they guide us around treatment choices. So that's the first thing I want to talk about. So looking, trying to get more information that helps, that helps give us more information about a patient and gives us more information to give to you. The second, and probably the one you're most interested in, is around the move to targeted treatment. So this is the timeline, and this is chemotherapy. So that's how we treat lots of cancers like breast cancer, colon cancer. They're drugs that kill cells, and they'll kill dividing cells, so they'll kill healthy normal cells, and they'll kill cancer cells. But we're moving into an era of targeted therapy. So if we look at what treatment we have in New Zealand, we've got chemoimmunotherapy. So the chemotherapy part, fludarabine and cyclophosphamide. The R is rituximab. That's the antibody that binds the CLL cells. We've got bendamustine, funded by Pharmac 2 to 3 years ago for CLL, a chemotherapy drug, but very effective in CLL. Obinutuzumab, a new generation of rituximab funded by Pharmac. And just recently, the targeted treatment, Venetoclax. But look at all these other drugs that we're still, the ibrutinib, the BTK inhibitor, idelalisib, and duvelisib, they're PI3 kinase inhibitors, and sitting, I'm not sure if it's under your arrow, but acalabrutinib, a next generation Bruton tyrosine kinase inhibitor. And just like when we looked at CML, we had targeted sort of therapies. This is what's happening in CLL as well. So here's a signaling pathway that's only in the B lymphocytes and the CLL cells. Here's the Bruton tyrosine kinase enzyme, and here's ibrutinib that targets that. Here's the cell death pathways, BCL2, so it stops cells dying. Venetoclax blocks that, so allows cells to die. Here's PI3 kinase. So these are smart drugs that are, that are acting in a smart way rather than killing off normal and CLL cells. So if we look, this is European guidelines for CLL, and this is for patients with early stage disease, but they're symptomatic or advanced stage. So we still, for patients that are asymptomatic, who have been diagnosed with CLL, but it's not affecting their blood counts and not causing them any unwellness, is that there's no evidence that early treatment, although it seems counterintuitive, there's no evidence that starting treatment earlier is going to improve outcomes for patients. And it has the risk of exposing people to drugs that might have side effects. With the new drugs, this is being addressed, and there's a big study from the German leukemia study group that is asking this exact question. So if you've got these smart drugs, if we start those earlier, is that going to be better? So we're waiting for those results. So the things to note here is that they look at treatment based on the molecular profiling. So here we've got the TP53 gene and are recommending a smart drug. So ibrutinib or acalabrutinib, the BTK inhibitors, and Venetoclax. And Venetoclax is funded in New Zealand for this indication. And here we've got the patients that have got a normal TP53 and are either a mutated or non-mutated. We've got the conventional chemoimmunotherapy, FCR or chlorambucil, obinutuzumab or bendamustine, rituximab. But internationally, you would also have the smart targeted drugs as well, and we don't have access to those. Is the smart drugs sort of better? Yes, there's a lot of studies looking at this, and I'll quickly go through those because we're nearing question time. But this is comparing ibrutinib and rituximab versus standard of care FCR. This is ibrutinib, this is FCR, this is looking at progression-free survival. There's no differences yet in overall survival. So there's better duration of remission, especially if you've got that mutated immunoglobulin gene. No difference if you're immunoglobulin gene is mutated, and so this is what we would tend to use in a younger patient. What about versus bendamustine rituximab? And again, here's ibrutinib either alone or with rituximab, and showing it's better than the bendamustine rituximab in terms of duration of response, not showing an advantage in overall survival as yet. But again, the benefit is mainly in people with that unfavorable molecular profile. And the Elevate study, looking at versus what we use in our older patients, obinutuzumab, chlorambucil, acalabrutinib's a second generation BTK inhibitor, so it's like ibrutinib. And again, here's what we would use. Here's these newer treatments for progression-free survival. There's a hint of improved overall survival. So you look at that and you go, well, gosh, should we still be using chemoimmunotherapy? I think it's still effective in young and fit patients. So that would be only half of our patients, so patients under the age of 65, sort of 70, and who have got a good risk molecular profile. So the FISH and the immunoglobulin studies, and this is not readily available at the moment. And I guess this is New Zealand, we've got limited access to novel drugs. This is where we really struggle around our the symptom, the relapse disease, where we've only got Venetoclax or rituximab, or using chemotherapy again, and we would like to have, and it will come, but it's slow. Just got one slide here to show you. Some of you with relapse disease may be on Venetoclax, and this is the MURANO trial, which was the evidence Pharmac used to show it was better than bendamustine. And you can see with long follow-up now out over 4 years, much better, and patients there's better survival as well. So that's good. And final topic, which I will quickly talk on, is depth of remission. So this concept of minimal residual disease. So it's a bit like the concept of looking for where's Wally amongst how do we find the leukemia cell out of all the normal cells. And we use flow cytometry to look for minimal disease. So we can pick them at down to not just 1 in 20 cells, but 1 in a million. And this is showing from the MURANO study that if you get really low levels, then you do really well. So this is my concluding slide before I do the questions, is what's new? Genomic testing, so that FISH and the immunoglobulin gene. Treatment advances are huge and around the targeted therapies. We've got Venetoclax, we want to have ibrutinib for you. We're now into the second generation drugs. So some of you may be on clinical trials with zanubrutinib, that's a new BTK inhibitor, and there's new BCL2 inhibitors. So that's the Venetoclax family, and this remission is becoming important. Natasha's going to shut me up soon, so I'm going to quickly race into questions. Joanne, CLR, watch and wait, life expectancy, low diagnosed. Okay, so yeah, I think I hope you've addressed that sort of question, that it's a worrying thing, but still that's our current state of sort of knowledge. Why does the PCR result appear to take so long to come back? I'm under Middlemore on my test, go to Auckland Hospital. I'm guilty of our lab is we just lost a lot of scientists. It takes a lot of scientist work. So normally the work on it is around, it should be 14, 15 sort of days. It's we've just installed a new machine, which they have in Christchurch and Wellington, which can turn it around faster. So that is being addressed. So apologise for that. Will Pharmac take on zanubrutinib to become the mainstream, having to continue with clinical trial? Not, I think the way Pharmac works is that the data's got to be published, and so I think ibrutinib is they've got to make. I think we'll see a decision on ibrutinib. What stage is FISH test done in New Zealand? Normally, it's done in a patient that's needing therapy. little bit of controversy. Should you do it in someone at their first sort of diagnosed? And the international guidelines sort of say, well, probably not, because it's not going to alter if you're not going to need to treatment. I have to say, sometimes I'll have a discussion with a patient, I'll sometimes do it earlier, but the guidelines suggest it's most important when you're choosing your therapy. Do I think ibrutinib will be funded here soon? I think they've just got to. I think the data is overwhelming. It's been in front of them. It's got a high recommendation. I think it will be. The rumours we're hearing are sort of positive.
Awesome. Hey, Peter, I might jump in. Sorry about that. You were burning through those questions. You're doing a great job. And thank you so much for a really thorough talk. We really appreciate it.
I knew you were going to stop me. I know, could I just say the watch and wait, are some of us potentially lucky enough never to need treatment? Yes, absolutely. There are some people who never need, who die at the age of 104 and never having needed treatment for their CLL. Yes.
Thank you so much, Peter. And for the other questions that we've missed, we'll see what we can do about getting those answered and then send out those answers.
Yeah.
Awesome. All right, well, on that note, I'll wrap things up for our session on chronic leukemia. So thank you again so much, Peter. We really appreciate your time.